Yeah, so this is a large part of my practice, and essentially it's a very elegant way of doing a hip replacement where the approach to the hip joint is made through the front of the body or the front of the hip rather than the more traditional way of doing it through the back. And in essence, what it allows is to do the hip replacement without cutting or damaging any muscles or tendons, and as opposed to the posterior approach hip replacement, which normally involves splitting muscles and cutting tendons into the hip joint. And essentially, by having this sort of elegant approach, the benefits conferred to the patient are those of having less pain, less instability, potentially early recovery, and possibly a higher level of functional outcome compared to the more traditional posterior approach. So there is great variability between patients, but on average, being somebody that does both the direct anterior and posterior approach, I can certainly say in my practice that the direct anterior or minimally invasive approach has a much easier, better, and greater recovery in terms of less pain, in terms of transition off crutches, in terms of return to work, and in terms of return to high level function. In fact, we've audited the results at Chelsea and Westminster Hospital, and we've found that I've been able to achieve a high level of day of discharge patients, so patients going home on the day, and even patients that stay longer, the discharge from physiotherapy or discharge home is significantly greater. And that's not just the experience that I have, this is an experience that's borne out in the literature around the world. Yeah, apart from the benefits we've talked about in terms of less pain because of less damage and destruction to the muscles and tendons, there are actually some practical and almost workflow benefits. When we do the direct anterior approach, the patient is supine or on the back. This allows me to measure leg length directly and perfectly. And so the risk of getting a limb length discrepancy, at least a significant one, is almost zero. Yeah. One of the other advantages is that I often do the direct anterior approach using X-ray because the patient's flat on the back. It allows me to do that. This means that my implant positioning is perfect because I'm seeing it directly. When you compare that to the posterior approach with the patient on the side, typically, assessment of limb length is a little bit more difficult, a little bit more nuanced, and we don't know ultimately about implant position until the end where we do a sort of day one post-op surgery, unless we are using adjuncts such as robotics and navigation, which I do use as well. Yeah, so the complication rate of hip replacements is well studied and well understood. And we talk about general risks such as infection, bleeding, nerve injury. And then we have more specific risks to the operation, which includes fracture, dislocation, implant malposition, and implant loosening needing further surgery. Overall, we think about the risk of surgeries between 1 to 3%, and there's a little bit of variability. And that variability is accounted by the surgeon's expertise. It's also accounted by the type of the patient. So patient habitus, patients who are overweight, the risks are slightly higher. Patients who've got significant medical problems, the risk can be slightly higher. But what's good about hip replacement surgery is overall there's a high level of good outcome, high rate of patient satisfaction. When we compare doing the minimally invasive direct anterior and posterior approach, providing that your surgeon is fellowship trained and a high volume, ideally a hip specialist surgeon, then we know that the complication rate between the two approaches is the same, which is low. And the way to answer that will be to understand that there's actually a lot of variability. And so it's all about probability. What we do know from looking at national registries around the world, including the UK, Australian, Finnish registry, is that 95% plus of patients, hip replacements will survive at least 10 years. And then we look between 15 to 20 years, that rate is about 75% when we take all comers. And when we look at hip replacement surviving over 25 years on the Finnish registry, we can expect about 57% of hip replacements to survive. What we do know is in the younger population, the survival rate can be slightly less, and this is to be expected because you're generally talking about more active patients who may wear out the implant. But one of the things that is very satisfying for me is that I know that the vast majority of patients who I do a hip replacement on will not need the hip replacement changing again in their lifetime.